Okay, let's tackle guidelines, folks. First of all, you need to know a couple of terms. The term encounter is used for any type of hospital or healthcare encounters or contact. So it's used for everything from hospital admissions to physical therapy home visits. Those are encounters. All right. When we're talking about guidelines, the term provider means either a physician or a mid-level provider or any other provider who is legally able to establish a patient's diagnosis. All right. So, guidelines are organized into 4 different sections. The first section is conventions, structure, and chapter-specific guidelines. They correspond, when we say chapter-specific, we mean chapter-specific as in chapters in the actual code book, not your textbook. Remember, our code book is made up of 17 chapters in ICD-9. Section 2 are our guidelines for selecting our principal diagnosis. Section 3 is guidelines for reporting any additional diagnoses or secondary diagnoses. And Section 4 are the outpatient guidelines. Okay, general coding guidelines. You use both the alphabetic and the alphabetic index and the tabular. We've discussed that, right? You locate your terms in the alphabetic, you find them in the tabular, and you follow any instructional notes. Level of detail in coding. Okay? Diagnosis and procedure codes are to be used at their highest number of digits available. So, if there are 5 digits available, you have to have 5 digits. Okay? You only use a 3-digit code if there is no further subdivision of anything. Okay? So, if you were to look up, well, let's keep going here for a minute. When there is a 4th-digit subcategory or a 5th-digit subclassification, you must use them. A code is not valid if it hasn't been coded to the full number of digits available. So, how do we know that there are more digits available? Well, number 1, we read, but number 2, there's also that visual cue of the dot, or if you have a colored, code book, the red dot next to the code, correct? If you have a red dot, that means you have more digits available that you need to code out. Once you code out and you don't have any red dot next to that code, then you're good, you're done, okay? So, if you were to look up the code 441, 441 would be invalid as to be used as a code. 4410 would be invalid to be used as a code. Why? Because you can continue. So there's a 5th-digit subclassification, so 441.03 would be valid. Okay? ICD-9 Volume 3, which are the procedure codes, have 3 or 4 digits. You will never have a 2-digit procedure code. Okay? You must always have either a 3rd and or a 4th digit. Okay? So if you look up code 55.5, that is not valid. If you look up code 55.53 or 55.53, that one is valid. Okay? You have to be as detailed as possible. When you are coding diagnoses, symptoms, conditions, complaints, or the reason the patient is there for the visit, the codes that you use, oh, sorry about that. That was my sister texting. The codes that you use are from 001.0 to V91.99. Those are the only codes that are usable for diagnosis or symptoms coding, etc. Signs and symptoms are acceptable to use as a diagnosis, as a diagnosis, as long as there hasn't been a definitive diagnosis established. So if you have a fever and you don't have any other diagnosis there, fever is acceptable to use. But if you have a fever and you have pneumonia or you have the flu, then you would not code the fever, because that's part of having the flu or having pneumonia. It's expected that you would have a fever, okay? So conditions that are an integral part of a disease process, you don't assign as codes, okay? So same thing. When we're talking about the fever and the flu or pneumonia, same thing. You don't code that fever because it's part of pneumonia, it's part of the flu, okay? If you have a condition that's not integral to part of a disease process that's there, so let's say maybe you have a fever and a broken arm that you just broke. Well, fever isn't necessarily part of a broken arm, so you might be coding that fever in addition to the broken arm, okay? You always have to check to make sure. Multiple coding for a single condition. There are times when you will be coding multiple codes. You'll have to have more than one code in order to completely represent a single condition. Many times you will know there are cues. You will see use additional code in the instructional notes to tell you that, hey, there is an additional code that you need to use here. Now, use additional code found in the tabular is not part of, use additional code indicates that a secondary code should be added. Okay, so use an additional code. It's the same sequencing rule as for etiology and manifestation. Okay, that's probably the best way to say it. So if you follow your etiology and manifestation rules for use additional code, you'll be fine. Okay, code first notes are found under certain codes that are not specifically manifestation codes, but could be part of an underlying disease process. Okay. Code, if applicable, any causal condition first. We've talked about these, right? If there is a causal condition, then you need to code that first. It's telling you right there, any causal condition first. So use additional codes, code first, code if applicable, any causal condition first, any late effect codes, any complication codes, obstetrical codes. Those are all things, triggers that you should be thinking, hey, I might need to have an additional code to fully identify what's going on here with this patient, okay? So, if you look here, we have examples of that. Code first underlying glaucoma, code first underlying condition, code first underlying condition. So pay attention is the key. That's the takeaway here, okay? Acute and chronic. So here is the deal with acute and chronic. If the same condition is described as both acute and chronic, okay, and separate sub-entries exist in the alphabetic index at the same indentation level, code both and sequence the acute code first. So that's really nice. What does that mean? Here's what it means. If you have a diagnosis of acute and chronic pancreatitis, you look up pancreatitis and you see that acute and chronic are both at the same indentation level. They both have a code. Acute is 577.0, chronic is 577.1. Then you must code both and sequence the acute first. Okay? Now, let's say you have a combination code. So what is a combination code? Well, a combination code is kind of like a compound word, A combination code, it can classify, it's one code, it's just the opposite. It's one code that can classify two diagnoses, okay? Could be two diagnoses. It could be a diagnosis with a secondary process or a diagnosis with an associated complication, okay? Assign only combination codes when the code fully identifies the diagnostic conditions involved. So what that means is you need to be very careful if you assign a combination code and be sure that that code is covering the two conditions that you want to code for. Okay? If it doesn't fully cover it, then you need to put another code on. Okay? Late effect. A late effect is a residual condition. And do you remember we discussed this in class? Residual, if you think about residual, what is residual? Its root word is residue. And what is residue? Residue is something that's left behind. So if you think of it as soap scum residue, okay? You take your bath and that's your acute phase. Taking your bath is your acute phase. Draining your tub is getting rid of that acute phase. The bath water is gone. But what's left behind is the soap scum. That is the residual effect. Okay? So a late effect is the residual effect or a condition after an acute phase of an illness or an injury has already resolved or terminated. Okay? Two codes usually are sequenced this way. Number one, the condition or the nature of the late effect is sequenced first. So that would be the soap scum. That is our condition. The late effect code is sequenced second. That would be a code that would describe late effect of a bath. We took a bath that caused soap scum. So late effect of a bath, okay? The only exception to this is when the code for the late effect has been expanded, and this will be expanded at the 4th and 5th digit levels to include the manifestations. So if you have a code that's a late effect that has expanded to be a combination code, then you would only use one code. All right? So here is an example, okay? We have scoliosis, we have poliomyelitis. Poliomyelitis 138, scoliosis 737.43. So it tells you what you need to do, okay? It just read your code book. Let it guide you. Let it guide you. It will hold your hand and take you down the road, okay? Impending or threatened. We talked about this in class as well. When you are coding an impending or threatened condition, if it occurs, you code it to the confirmed diagnosis. So if you have an impending or threatened abortion and the mother miscarries, then you code the miscarriage. Okay? If it doesn't occur and we've admitted them to the hospital, we've got to say why we admitted them to the hospital. Well, we admitted them to the hospital because of a threatened abortion. They were going to lose that child. So we admitted them and treated them. If it didn't happen, then you're going to go under impending or threatened as your main term. Okay? And follow from there. It will lead you as well. It will tell you what you need to do. Okay? If subterms are listed, then you use the subterms. So if there's a subterm there, make sure you ski all the way down the slope, right? If there are no subterms listed, you code the conditions, the underlying conditions, and not the condition described as impending or threatened. So if there was an underlying condition, maybe they were threatened abortion and maybe they were low on magnesium, extremely low, dangerously low, then that's what you would code, the low magnesium level. All right? When you are coding, only one ICD-9 diagnosis code should be reported per encounter. So what does that mean? That means that you'll have lots of diagnosis codes, but you should never have one that repeats in the same encounter, okay? If you have someone who's being admitted for rehabilitation purposes, then you use code from the category V57. If they are having multiple rehab procedures, then you use code V57.89 with procedure codes. So V57.89, don't get it confused. It is a diagnosis code. Even though it only has 4 numbers, it is a diagnosis code. Do not confuse it and think it is a procedure code. It is a diagnosis code, and if you use that code, then you must use procedure codes to correspond to tell what type of therapy you had performed on a patient. All right? BMI, documentation, and pressure ulcer stages. These are secondary diagnoses. You can use documentation from a nurse. You can use documentation from a wound care specialist. You can use documentation from people who are other than a physician or a mid-level provider. As long as you have a diagnosis of either a pressure ulcer or obesity. That's your diagnosis. The stage or the BMI is just additional information, okay? So that is acceptable. Syndromes. We've talked about syndromes already, okay? Documentation of complications of care. In order to code something as a complication of care, you must have the physician state that it is a complication due to a procedure, due to a medication that was given, due to something that was done to that patient while they were in the hospital. Because not every condition that follows a surgical procedure or medical care is necessarily a complication. And it's not our job to decide that. It's the physician's, okay? We don't get to assume that. All right. Selection of the principal diagnosis. That is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. If you don't know that, know it. Learn it. Okay? You must know it. This is the definition that the UHDDS has provided that we are to follow. Okay? So, coding for symptoms, signs, and ill-defined conditions. We talked about this. You don't code a symptom if you have a definitive diagnosis established. 2 or more interrelated conditions, each potentially meeting the definition for a principal diagnosis. Hey, what if you have 2 things that could be the principal? What do? You can sequence either condition first. It does not matter. Okay? It's entirely up to you. What if you have 2 or more diagnoses that equally meet the definition of principal diagnosis? We talked about that. It can already be, we talked about the sequencing. 2 or more comparative or contrasting conditions. Well, what do we do there? Well, number 1, you code as if the diagnoses were confirmed, and the diagnoses are sequenced according to the circumstances of the admission, meaning you go back to the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. You go back to relying on that. You do code them as if they were, if it says that it could be this or it could be this, you code them both as if they were confirmed. If no other determination can be made, either diagnosis can be principal. Okay? And with this one, you will a lot of times see either or documented by the physician. Either or. this, okay? What do you do if you have a symptom that's followed by a contrasting or comparative diagnosis? The symptom is sequenced first because we don't have a definitive diagnosis, right? We have two possible, but we don't have an actual definitive diagnosis. So in that case, we code the symptom first, okay? So it would be fever, and then you would see pneumonia, either or pneumonia or influenza. Either pneumonia or influenza. And if you have that and you have fever stated, then you're going to sequence fever first. Okay? What if you are doing you have a treatment plan, patient comes in, they're admitted to the hospital, everything's assessed, there's a treatment plan that's put in place. However, that treatment plan does not get carried out for whatever reason. That does not affect the assignment of the principal diagnosis. You still sequence the principal diagnosis as the condition after study that occasioned the admission to the hospital. You continue to revert back to this. Okay? Now we have complications of surgical and other medical care. When you have that, a complication code will be sequenced as your principal diagnosis. Okay? If you have a diagnosis that's uncertain, that would be suspected, probable, possible. Rule out, you will see. Rule out, R-U-L-E-O-U-T, not ruled, rule out. If it's going to be rule out, then you code it as if the condition existed or was established. Because while somebody's in the hospital, we are still treating them for that, right? We're monitoring, we're evaluating, we're trying to find out what it is. We're trying to establish that it's something. So you code it. Okay? If you have someone that's being admitted from an observation unit, okay? So let's say you are admitted for medical observation, and they decide, they hold you and they decide, you know what, yes, we need to keep this person. Then the principal diagnosis is still going to be the condition that led to the hospital admission. Admission following post-operative observation. So you go in for surgery, outpatient surgery, and they keep you for post-operative observation, and they decide to admit you, then we revert back to what? The condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Okay? What if we have admission from outpatient surgery? Okay, so number one, if the reason is a complication, you assign the complication as the principal diagnosis. You had a complication with anesthesia. Okay? If there's no complication or another complication, it's documented as the reason for an inpatient admission. You assign the reason for the outpatient surgery. So if somebody's coming in for, let's say they're coming in for an outpatient transvaginal hysterectomy, but there's no condition, they just want to admit the patient afterwards. We do this a lot. We do the surgeries as outpatient and then admit the patient after the surgery. If that's the case and there's no complication, then we list the reason for the outpatient surgery as the principal diagnosis. Uterine fibroids, so we did a transvaginal hysterectomy. Okay? If the reason for the inpatient admission is another condition that's not related to the surgery, you assign the unrelated condition as the principal diagnosis. So, patient goes in to have, we'll say, what could we do? We have a man that comes in for a circumcision. Happens quite often, actually. And while they're there, they get a little groggy with the medicine, and they get out of bed and they fall, and they break their leg. We have to admit them because of the broken leg. That broken leg is not related to the circumcision, right? So that is the reason for the principal diagnosis. That is the reason for the admission. That's the principal diagnosis. Okay? Other diagnoses. General rules. Here's the general rules. It has to be clinically evaluated. So we run, I don't know, we look at it, the doctor looks at them and says, you know, I don't know, they've got this symptom, this symptom, this symptom. I'm thinking maybe this is what's going on. Has to be therapeutic treatment. We take them in for surgical procedure. We give them antibiotics. We do something therapeutically to help them with it. Diagnostic procedures. We do x-rays. Extended length of stay. So the idea is if you have a diagnosis that's secondary that increases your length of stay or increases your nursing care or monitoring, then we report it. Okay? Again, important for you to know. If you don't know this, you need to learn it. You need to learn it, okay? Other diagnoses, all conditions that coexist at the time of admission. Anything that develops while they're there, or anything that affects the treatment that they get or how long they're there, that's what you're reporting. It applies to inpatients, short-term care, long-term care, psychiatric. That's what it applies to, okay? So if they come in with it, if they develop it while they're there, or if it affects their treatment or increases their length of stay, you report it. Some providers will include resolved conditions or diagnoses that have already been taken care of. They're no longer an issue, or what we call status post procedures. Status post means you've had it done. So status post hysterectomy, that means that that patient has had a hysterectomy in the past. At some point, they had a hysterectomy, okay? But it doesn't really affect the reason that they're there. It doesn't really affect. They have pneumonia. They were in a car accident, okay? Maybe they had uterine fibroids, but they were in a vehicular accident. That doesn't have any bearing on the reason that they're there at that point in time. We don't treat it. We don't monitor it. We don't do anything to diagnose it. We don't take x-rays. We don't do anything. It doesn't increase their length of stay. It doesn't increase their monitoring. If that's the case, we don't code it. The only time we code it is if your hospital will say we want this coded. Now, why would a hospital say that? Sometimes you have to think back to why we gather information and what we use the record for. And there may be something, and you learned about this in your 101 class. What are the uses of the health record? Well, they're used for operational purposes. They're used for reporting purposes. They're used for education. There may be a study going on in your hospital about something. There may be, there may be something perhaps they want to. Perhaps your facility wants to open a certain type of service up, but they have to have enough information and data to back it up. That would be when your hospital policy would say, hey, pick this code up and code it, okay? Otherwise, you don't, okay? Let's say somebody has a history or there is a family history, and many times you will see this. And here's the best example I can think of. Breast cancer. Family history of breast cancer, and we'll see this a lot with breast cancer. Let's say we have a patient that comes in for, I don't know, they come in for, there's something going on, and there is a family history of breast cancer, and it does have bearing on this case. Or perhaps they have a history of breast cancer, and they have a history of a mastectomy. In that case, there will be many things. If you have a mastectomy on the right breast, then your right arm is no longer any good for IVs. It's no longer any good for any type of venous access or arterial access. You leave that arm alone. That would have an impact on your care. So you would want to put history of breast cancer, history of mastectomy, okay? Abnormal findings. Okay, this is one that you will very often see, abnormal findings in your records. If you were to look at my record at any given time, you would find that my white count is high in my blood. That is an abnormal finding. However, my white count is always high. I always run a low-grade fever. That is not something that we would report. Although there is a main term of abnormal that you can go in and find, abnormal findings, you will not report those unless the physician tells you to or wants you to. Now, if you think it is significant to what's going on with the patient's encounter, then you would want to query your physician and ask, what is the clinical significance of this white blood count finding on such and such a date, period, okay? Otherwise, we don't code those. Uncertain diagnoses, we talked about this. Code the condition as if it was there, existed or established. So if you see the word suspected, probable, anything that you think uncertain, possible, rule out, anything along those lines, you code it, okay? Outpatient services. Those are coding guidelines for outpatient services. They're to be used for outpatient visits and provider-based office visits. So what does that include? Ambulatory surgery. That includes x-ray, lab, any type of imaging, any type of interventional radiology, any type of office visit. That's what we use these guidelines for. Now, present on admission. Present on admission is something that was mandated by the Deficit Reduction Act. Basically, the reason is it became effective in October 1st. And basically, the reason is that the idea is we have to tell them, every diagnosis that we list, we have to tell them if it was present when the patient was admitted or not. Because if it was not present when the patient was admitted, then it is assumed that we gave it to them, we did it to them, or we didn't do something that kept them from getting it. Pneumonia, a fall. Patient comes in, they don't have pneumonia, they have surgery, they develop pneumonia. That is not present on admission, and therefore it is considered that we did not do something we should have done to keep that patient from obtaining pneumonia or from contracting pneumonia, okay? That is all they're for. They're to differentiate between conditions that we developed during the hospitalization and conditions that were present when we admitted the patient. Now, why is that? Because, why is it part of the Deficit Reduction Act? Because if we did it to them, or if it's something that is not present on admission, the federal government will no longer pay for it. Hence the Deficit Reduction Act. If we didn't do what we were supposed to do, then we're not going to get paid for it. Okay? These are the codes. A Y means that yes, it was present when they were admitted. An N, no, it wasn't present when they were admitted. U is unknown, that the documentation from the physician is not enough to decide if it was present when they were admitted or not. W is when the provider is not able to clinically determine. They just don't know. They have no clue whether it was there or not. They cannot clinically figure it out. Okay? Any unreported or exempt, and there are some codes that are exempt from POA reporting, when they print out on the electronic claims, they will have a 1 instead of a Y, an N, a U, or a W, okay? All right, so why is this? Let's go into this a little bit more. CMS, which is our Center for Medicare and Medicaid Services, has identified certain what we call hospital-acquired conditions, or HACs, that they will no longer reimburse us for if there are extra costs incurred as a result. That is where this comes from. They're identifying the ICD-9 code and the POA indicator of N. Okay? This is only applicable to hospitals that are reimbursed under the IPPS, which is the Inpatient Prospective Payment System. And you will learn more about this when you take your reimbursement methodologies class next year. However, there are hospitals that are exempt. They are as follows: cancer hospitals, children's inpatient facilities, rural health clinics, federally qualified health centers, religious non-medical health care institutions, inpatient psychiatric hospitals, inpatient rehabilitation facilities, and Veterans Administration and Department of Defense hospitals are all exempt from the present on admission indicators. Okay? Now, if a condition is on the exempt from reporting list, you leave that POA field blank. Okay? That is the only time you could have a field blank, is if it is on the exempt from reporting list that is put out by the federal government. Okay? If a POA is explicitly documented, you give a Y as yes, they had it. If it's explicitly documented as no, they did not have it, you put it as an N. Okay? Another way to help, remember, conditions diagnosed before the inpatient admission, you give it a Y. Conditions diagnosed during the admission but were clearly there before admission, it's a Y. Condition develops during an outpatient encounter prior to an inpatient admission. It is still a Y because that inpatient encounter is different from the outpatient encounter. What if your documentation doesn't indicate whether the condition was present? Then you give it a U. You should not use U on a regular basis. You need to try to figure out Y or N. That is a red flag for CMS, and they will start looking at your records. Okay? Documentation states it can't be determined whether the condition was POA. You assign a W. Only if the documentation states it can't be determined. A chronic condition with acute exacerbation during an admission. So let's say a code is a combination code that has both the chronic condition and the acute condition. You're going to check out the POA guidelines about acute and chronic and combination codes, okay? And let me see if I can find that for you here. Nope, you're going to have to look that up. I want you to look that up. Look that up and see what that says. If a combination code only identifies the chronic condition, you assign a Y, because chronic means they had it before they came in, right? They had to have had it before they came in. Conditions that are possible, probable, suspected, rule out, those are assigned a Y. Okay? Let's say a diagnosis was based on signs or symptoms or clinical findings that weren't POA, then you assign an N. This is really pretty straightforward stuff. You guys can do it. It may seem a little daunting, but you can do it. Okay? It is possible. You can do it. All right? Conditions that are documented as impending or threatened at the time of discharge. And let's say the diagnosis is based on symptoms or clinical findings that were there when they were present, when they were admitted. It's a POA. It's yes. And let's say the diagnosis is based on symptoms or clinical findings that were not there when they were present, when they were admitted. Then you assign an N. Here's your acute and chronic POA indicators. Assign a Y for acute conditions that are present at the time of admission and an N for acute conditions that are not present at the time of admission. Pretty simple. Assign a Y for chronic conditions even though the condition may not be diagnosed until after admission. Because again, chronic means you've had it for a long time, right? Let's say you have a combination code. If any part of a combination code was not present on admission, you assign an N. You only assign a Y if all parts of the combination code were present on admission. Otherwise, it's an N. Okay? Let's say your final diagnosis has an either or, comparative and contrasting diagnosis. Both were present or suspected at the time you were admitted, patient was admitted, it's a Y. For an infection code that has a causal organism, so a urinary tract infection with E. coli, okay? You assign a Y to that E. coli even if the culture results are not known until after admission. Sometimes those culture results aren't even available until after discharge. But it was obviously there at admission. You code it with a Y. Okay? Same diagnosis code for 2 or more conditions. You assign a Y if all the conditions were represented by the single code. Assign an N if they were not. Okay? And what I would suggest to you is I would go through and I would make these my flashcards. What do you do? What do you do if all conditions are represented by a single code were POA? You assign a Y. What do you do if a pregnancy complication or obstetrical condition was POA? You assign a Y. Okay? I would make these my present on admission indicators. I would make these my flashcards. Okay? Congenital anomalies are Y because congenital anomaly, congenital means you had it at birth, right? Okay? Go through and read these. Go through and read these, and these will make more sense as we start to use them. Okay? We will start to use these as we code. So they'll make more sense. I promise they will make more sense, okay? If you have any questions, please let me know.